Hi everyone, I am Dr. Sagar Sav and welcome to Vet Surgery Teach. So first of all, a very happy new year to you all. May Lord Jagannath bless you with all the happiness and prosperity. So from today we will be starting the radiographic pathology of thorax, the most demanding one. Okay, so before watching this pathology series, do watch the normal thorax interpretation. Okay, I have already made that video. I will give the link in the description, and also we have covered the radiography pathology of the abdomen. I will also give the link to all those videos in the playlist. Okay, do watch them. Okay, but before watching this pathology, do watch the normal thoracic interpretation. From today we will be starting the upper airway system, though larynx and is not inside the thorax, but they are part of the respiratory system, so we will be covering that. So today we will be discussing the larynx and trachea. So first of all, let us know some anatomical structures which you can find in the radiograph. So this is basically the pharynx. Okay, so let us start from the cranial to caudal. So this is hard palate, this is hard palate. Okay, so this is the internal nares, this is nasopharynx, this entire structure is nasopharynx. Okay, this structure is soft palate, this is soft palate. Okay, this thin line is epiglottis. Okay, and this structure is oropharynx, this one is oropharynx. Okay, and this structure is the laryngopharynx. There is a common pharynx. Okay, and this epiglottis which is present here while the animal swallows, it will go to this structure and close the larynx or laryngeal opening. Then the esophagus usually present dorsal to this larynx, and the esophageal sphincter will open, the food will enter the food pipe, that is esophagus. Some structures, other structures you should know, that this hyoid apparatus. Okay, many times when you will be beginner, this hyoid apparatus you may confuse with some fish hook or any bone stock in the pharynx, but this is hyoid apparatus. It has several bones. This bone all are paired. So this one is stylohyoid, stylohyoid. This bone, this is paired bone, this is epihyoid bone. This bone here is ceratohyoid bone. This bone is basihyoid bone, and this bone is thyrohyoid. Okay, so these are basically hyoid apparatus which will normally find in the pharynx. It is not any kind of pathology, or sometimes when the animal will come to regarding they have eaten some fish or meat and the bone piece has been stuck in the pharynx, it is doing the retching. Okay, characteristic retching. So while taking an X-ray, you may find this hyoid apparatus and you may confuse with some bone stuck in the pharynx, but they are basically the hyoid apparatus. Note this shape. Okay, this is hyoid apparatus. We will see multiple radiographs, you can identify the hyoid apparatus. Okay, let us see another radiograph where we will identify different structures. So this is another radiograph. Here actually the hyoid apparatus is much more clear. So this is the nasopharynx, this one is the oropharynx, common pharynx, laryngopharynx. Okay, now see the hyoid apparatus. Okay, this is stylohyoid, epihyoid, ceratohyoid, basihyoid, thyrohyoid. Okay, this is hyoid bones, hyoid apparatus. And you can also notice some cartilages. This one is one cartilage, this is another cartilage, and there is a triangular piece cartilage. We will see also some better picture of cartilages. So this is arytenoid, arytenoid cartilage. This is thyroid cartilage, thyroid, and this is cricoid. Okay. So in case of old animal, these cartilages may get mineralized. When they will be mineralized, you will find very nice picture. This is a picture of old dog which have some mineralization. You can see these cartilages. Here is one cartilage, this is another cartilage, and this is another cartilage. So this is arytenoid, thyroid, and the cricoid. Okay, also there is the mineralization of the tracheal rings, and you will find in old animals. Let us also see the hyoid apparatus. This is stylo, epi, cerato, basi and thyrohyoid. Okay, so these are the structures you will commonly find in the pharynx. Next the larynx, then this is the trachea. You will find tracheal rings. This is basic anatomy of the pharynx and the trachea, or basically larynx and trachea. So let us go to another important thing, the trachealis dorsalis membrane. What happens in case of dog and cat? The tracheal rings are incomplete. You know that the tracheal rings are incomplete. Here there will be membrane. This is tracheal dorsalis membrane. Sometimes what will happen, this membrane will hang below. Instead of being straight, it might hang like this. So when you will take X-ray, it will be rotated and you will find something is hanging from the dorsal tracheal wall. This is dorsal tracheal wall. This is ventral tracheal wall. You will find something hanging. It is of soft tissue opacity. This is soft tissue opacity. This is nothing but the dorsal trachealis membrane or trachealis dorsalis membrane. This does not have any pathology, but you know that it should be differentiated from, differential diagnosis is the ventral deviation of esophagus. It means sometimes the esophagus is actually dorsal to the trachea. Sometimes this esophagus can put pressure and come into this trachealis membrane, and what will happen? It can produce same lesion. Okay, so the thing is, the prolapse of, it is also known as prolapse of trachealis membrane, is dynamic. Okay, it means it is different in expiration and different in inspiration. Sometimes it may not be visible in inspiration, but it is visible in expiration. So you may go for fluoroscopy to differentiate between this. Okay, here you can see, here sometimes you may get confused that this might be prolapse of trachealis membrane, but remember, this is not, this is esophagus. This is actually esophagus in which the gas is present. This is esophagus. The ventral wall of esophagus and dorsal wall of trachea is forming a band-like structure. Okay, so that is how you can identify this is esophagus and this is trachea. It is not prolapsing into the trachea, that is through the trachealis membrane. Okay, so they are incidental findings. Better is go for fluoroscopy so that you can identify. Here is another picture in which you will find that the esophagus has been entered into the trachealis, through trachea through the trachealis. See carefully. So this is the trachea, the black arrows. This is trachea. Can you see a structure, gas filled structure like this here? This is actually esophagus. Due to presence of gas, you can tell that the esophagus is actually into the trachea. Through the trachealis membrane, it has come down. Okay, that is why you are finding this soft tissue opacity which is hanging from the dorsal wall. Okay, so this, in this way you can differentiate whether the esophagus has come down or the only the trachealis membrane is prolapsing or hanging down. Okay, so this is normal finding. It may not have any pathology, but when the esophagus is coming down, it might lead to some pathology, but normally they are dynamic in nature. Okay, they are different in expression and inspiration, so you may not find any pathology or any symptoms even. Next, the positioning. You see, you can take lateral view or VD view. Usually lateral view is more useful than the VD view, because in the VD view the trachea is superimposed by the spine. That is why you may not able to differentiate different pathologies, but they are complementary to lateral view. Lateral view is more useful, but they are complementary. Sometimes the lateral deviations and the lateral pathologies can be identified from the ventrodorsal view, so you have to take two views. So for lateral view, you have to make the animal in right lateral or left lateral recumbency, and also you have to make sure that head is mildly extended. Head is mildly extended, and the limb, it should be extended cranially, Okay, why this? For this cranially, these two radiographs differentiate. Okay, here the limb is not extended, due to which there is slightly dorsal deviation of the thoracic, cranial thoracic trachea. Trachea can be, this is cervical trachea, this is thoracic trachea. Okay, you can differentiate the trachea in two parts, the cervical and the thoracic. Here you will find, because the limbs are not extended, you will find some dorsal deviation. Sometimes this can be misinterpreted as there might be some mediastinal mass which is causing the dorsal deviation, right? But When the position is changed, when the limbs are extended, you can see the pathology is gone. So simply this is a normal thing, because the position was not right, that is why it was showing some dorsal deviation of the trachea, but in reality there isn't any pathology. Okay, another thing for you, the question, can you identify that which one is left lateral, which one is right lateral? This is left radiograph, this is right radiograph. You have to differentiate and comment down below that which one is the left lateral view, which one is the right lateral view. I have already discussed in the normal thoracic video, normal thoracic interpretation video, so you have to see that and comment down below. Okay, in lateral view there are some parameters which you should know. Usually the cervical trachea, they are parallel to the spine. Okay, when they will enter through thoracic inlet, they deviate from the spine. This is spine, usually they will deviate. In this picture you can see clearly, so this is spine, they will usually deviate. The angle is usually 10 to 15 degree. Okay, another thing you have to remember, that thoracic inlet to tracheal diameter to thoracic inlet ratio, this ratio is usually expressed in percentage. So what is tracheal diameter? This is tracheal diameter to thoracic inlet, first thoracic vertebrae to manubrium of sternum. Okay, you have to measure these two lengths and take a ratio. In case of non-brachycephalic breeds, the ratio, normal ratio is 20% plus minus 3%, while in case of brachycephalic breeds, the ratio is 16% plus minus 3%. But in case of bulldogs, which are highly brachycephalic, you can say, in case of bulldogs it can go as low as 13%. Okay, in some bulldogs it can go up to 9% without any symptoms also. Okay, so we have to take care of the measurements. But normally for non-brachycephalic 20% plus minus 3%, for brachycephalic it is 16% plus minus 3%. Similarly for cats, in case of cat, for Persian cat it is 20%. For short-haired cats it is 18%. Okay, so these are the thoracic tracheal diameter to thoracic inlet ratio, which usually determines the tracheal hypoplasia, whether the tracheal diameter is adequate or not. So these are the normal things which you have to evaluate from the lateral radiograph. One thing is the deviation, second one is the ratio. Okay, do comment down the which one is the left lateral, which one is the right lateral. Okay, next, the ventrodorsal view. Usually they are limiting because of the spine. The spine actually interferes the evaluation of the mostly the trachea. But you can, some things you have to notice, that usually trachea is not exactly at the middle, it is slightly deviated towards the right side. This is the trachea, this is the bifurcation here. Okay, this is the trachea. So usually the trachea lies slightly towards the right side. This is left side, this is right side. But in case of brachycephalic breeds, and if the dog is highly obese, in case of obese dogs, usually the mediastinum contains high amount of fat. You can see here the mediastinum is slightly thin, but in this particular picture you can see the mediastinum is very thick due to presence of high amount of mediastinal fat. This fat presence deviates or kinks the trachea completely towards the right hand side. So you should not interpret that there is some mediastinal mass which is causing the deviation. In case of obese and brachycephalic, it is normal. Okay, that I want to highlight in ventrodorsal view. Okay, so these are the normal survey radiographic views. Let us go to our pathology. First we will do the pathology of pharyngolarynx. So in case of pharyngolarynx pathology, first is masses, or you can say neoplasia or tumor or any type of mass. Usually any new growth is neoplasia. Okay, so the masses can be extramural mural, or it can be mural or luminal, intraluminal. Extramural means it occurs, mass occurs outside the larynx, pharynx or trachea, but it has some effect on this pharynx, larynx and trachea. Mural means when it originates from the wall itself. Intraluminal, when it projects into the lumen, there is very thin line of margin differences between the mural and the intraluminal. So here let us see some radiographs, then you can appreciate. So here you can see that the pharynx, larynx and the trachea is slightly deviated towards ventral side. You can clearly see there is some mass here, soft tissue opacity. Any mass will have a soft tissue opacity. So here you can see the soft tissue opacity. Also you can see the spine is slightly kinked. Okay. Before going to radiography, you might you might have the palpated the physically. Okay, you can see that some growth is there. So this deviation is extramural. This is an example of extramural mass. By this you can tell some mass is there which is affecting the pharynx, larynx and the trachea. This is deviation of pharynx as well as the trachea. When I'll tell you the pathology of trachea, I will also tell these masses. So here you can see some example. Okay, there might not be any radiographs. So here this is also extramural. You can see there is nasopharynx here which is slightly compressed. You see, if you will see the lumen diameter, okay, the larynx has the largest. Before that, pharynx is the largest actually. First is the pharynx, then the pharynx, then the larynx, then the trachea. Okay, so you can see here the pharyngeal diameter is lessened, and also you can say that there is something soft tissue opacity here which is causing the narrowing of the pharyngolarynx. Okay, in case of cat it is mostly cellulitis. Okay, mostly cellulitis. Let us see some other radiographs also. Here you can see there is a complete abolition of the pharyngolarynx. Here this is actually the endotracheal tube which is keeping the airway patent. Otherwise there isn't any space left. Okay, it's this particular X-ray was a case of mast cell tumor in pharynx actually, which was causing the complete abolition of the nasopharynx and the pharyngolarynx. Okay. Here you can see this is the larynx actually, this is the hyoid apparatus. Okay, stylo, epi, cerato, basi and thyro. So you can see here a soft tissue opacity. Okay, this is a mass inside the larynx. Okay, these surgeries can be done endoscopically also. Next, the pathology is trauma and foreign body. The most common cause of trauma is penetrating wound. So this penetrating wound can be from outside. Someone might hit the animal with some sharp object, or they may shot bullet at the animal, or it may be inside the body while eating some like bone pieces, sharp bone pieces. It can puncture to the esophagus or pharynx and it may cause some rupture or trauma or foreign body syndrome in case of animals. Okay, this particular is X-ray of cat. You can see, when there will be any trauma or foreign body or some pathology, you will find different type of opacities. If you are finding particularly only soft tissue opacity, so you may suspect for that might be hematoma or myositis, inflammation of muscle, myositis, or it might be cellulitis, inflammation of connective tissue, cellulitis. Okay, but if you are finding gas opacities, then there might be chance it might be a case of emphysema or abscess. Okay, usually when you will find linear gas opacity, that is basically the emphysema. If you are finding focal and round like structure like the pockets, then it is abscess. Okay, but it can be intermingled. So in this particular X-ray, let us see here. You can see this region the entire region is having some gas and soft tissue opacity, mostly might be abscess, and here this particular case, particular region, you can see it is soft tissue opacity, which might be due to cellulitis. Okay, this is basically a cat. Cellulitis is very common in case of cats, but here you can also see some foreign body. Okay, this foreign body is causing these problems. Okay, so this is basically trauma and foreign body to pharyngolarynx. Next, the brachycephalic syndrome. You see, brachycephalic breed has some problem, and that is pronounced as some syndromes or signs. So, brachycephalic syndrome has some primary signs or primary syndromes and some secondary syndromes or secondary signs. What are the primary signs? You will find the elongated soft palate, which is primary sign, elongated soft palate. Also you will find enlarged tonsil, okay. Secondary signs, you may find laryngeal and tracheal collapse, There are some other signs also, but these signs are radiographically pronounced, or you can identify through radiography. Although the tonsil you cannot identify, but this soft palate elongation you can identify radiographically, and also this collapse you can identify radiographically. One more thing, the elongated soft palate is basically a static thing. Okay, so you may find in normal survey radiographs, but for laryngeal and tracheal collapse you may need fluoroscopy. Okay, because depending on the expiration or inspiration, they may collapse or they may not collapse. I will show you some radiographs also. Okay, there are some other symptoms also, but signs also, but they are not radiographically, you may not appreciate. So this particular case, you can see the soft palate is slightly swelled up, means it is elongated or like fleshy, more fleshy. Okay, and here this particular radiograph you can find the laryngeal collapse. Okay, laryngeal collapse is a dynamic thing. Okay, so we have to take, if you do not have fluoroscopy, you have to take at peak inspiration and peak expiration, two radiographs. There is some photos of fluoroscopy also. This is fluoroscopy. This is inspiration radiograph, inspiration. This is expiration radiographs. Okay, so during the inspiration you can see the pharyngolarynx, and during the expiration you can see the pharyngolarynx. So you can clearly say that during the inspiration it has been collapsed. Okay, but in case of expiration it is not. So while taking the radiograph, you may take radiograph of expiration and diagnose it as that there isn't any collapse, but you have to take fluoroscopy or you have to take two radiographs at peak inspiration and expiration to differentiate, or you can diagnose it as brachycephalic syndrome. Next, let us go to the diseases of trachea. Similarly, I told, just like the masses of pharyngolarynx, these masses can be extramural and mural. Okay, so the mural masses is very easy to diagnose, because inside the trachea air is present. Air provides very good contrast for diagnosing any kind of masses, or even foreign body. We will also go for foreign body. So here is a mass, okay, which can easily be diagnosed. But for extramural, there are basically three locations where it may affect the trachea. When there will be extramural, then the trachea may deviate. It may deviate from its normal location, or it may narrow down the lumen. Okay, let us see some radiographs also. I show you the radiograph of that, this masses of pharyngolarynx. Here you can see the ventral deviation of the trachea. There is ventral deviation of the trachea. This is extramural. Also there are two other locations. Let me show you here. Here, though this isn't pathology, but if there will be any mass in mediastinum, okay, this is extramural, then there will be deviation of the trachea. Also, during dilated cardiomyopathy, if the heart is too enlarged, then this particular carina, instead of deviating at 10 to 15 degree angle, it may go up, or the degree of angle will be less, and you can identify that some mass in base of the heart. Mostly it is due to the dilated cardiomyopathy. One more thing, Here you see, let us see here. Here is very much nicely seen. This is actually trachea. This is trachea. Can you see another gas filled structure like here? This is basically esophagus. Esophagus. Okay, esophagus. And this characteristic appearance, if you will join them, it seems like this is a gas filled structure. There is a stripe. This is known as tracheal stripe sign. When I will teach you the esophagus, there I will mention it in detail, but for your reference you should know that. Okay, tracheal stripe sign, it is one of the sign for diagnosing the mega esophagus. Okay, so this is tracheal stripe sign. This is tracheal stripe sign. I will discuss when I will discuss the esophagus. So this is basically the masses of trachea. Very easy to diagnose, the mural and also the extramural depending on the position. This is foreign body. The most common cause of foreign body in trachea is aspiration. Okay, aspiration pneumonia, you can say that, aspiration. Okay, the most common location is carina. Okay, carina is the place where the trachea bifurcates. Okay, carina. Here you can see this is carina. Okay, triangular ending carina. Here you may find at the carina just cranial to the carina. Here you can see a foreign body. This particular patient has taken some rocks. Okay, so this is a rock. Here this particular patient, as per the book, has eaten some peanuts which was aspirated in the respirator. This peanut was endoscopically retrieved. Okay, here you can see. Usually it is pointy. When the carina at the end, it will be pointy, but instead of being pointy, there is some radio opacity. Okay, so this was the peanut. This was a case of peanut aspiration. Peanut. Okay, so these are the tracheal foreign body. They are easily diagnosed because of gas present, which provides the contrast. Next, rupture or avulsion of trachea causing stenosis. In this particular X-ray, esophagus has been marked by the gastro-feeding tube. Gastroenteric feeding tube. Okay, this is feeding tube in the esophagus. Now you have demarcated the esophagus. Now notice the trachea. This one is the carina, and notice the trachea. Here there is a gas filled structure. Okay, or you can say gas filled distension from the trachea. Okay, so this distension has been marked by a soft tissue opacity. These are soft tissue opacities which is marking this dilation or distension of this trachea. This location is also important. Usually this distension happens 1 to 4 centimeter cranial to the carina. Okay, so this particular thing is known as a pseudo airway. Pseudo airway. When you will find this condition, pseudo airway, then you may suspect that there is rupture or avulsion of the trachea. Okay, these are very rare conditions, but if you are finding, then it's a good thing that you can diagnose these things. Next is tracheal hypoplasia. Tracheal hypoplasia means a generalized reduction in the size of the or diameter of the trachea. Generalized. Okay, generalized. I told you regarding the tracheal diameter to thoracic inlet ratio, you have to calculate this one. In this case, you can, by seeing also, you can see that the trachea is hypoplastic. Okay, next and the last one is tracheal collapse. Okay, tracheal collapse. So the tracheal collapse is very common in case of middle to old age dogs. Middle or old age dogs. This is very frequent in case of small and toy breed dogs. Small or toy breed dogs. Okay, and the most characteristic sign is the chronic cough. Chronic cough. This might not respond to any medicine. Chronic cough. This collapse can be static. It can be static or dynamic. Most of the time this is dynamic. Okay, dynamic. This is the most of the time it will be dynamic. So for dynamic collapse, you need fluoroscopy to diagnose, or you can take multiple radiographs at peak inspiration and peak expiration to diagnose whether there is collapse or not. For static, there is a particular portion of trachea Usually location wise it can be divided into two, that is cervical tracheal collapse, cervical, or it can be intrathoracic. So in this particular radiograph, which is basically the static one, you can see the cervical trachea has been collapsed. But it is, if it is dynamic, then you have to go for fluoroscopy. For tracheal collapse diagnosis, fluoroscopy is the standard choice or the most better choice. Better choice, sorry, wrong English, most better choice from the radiology. So this is the inspiratory versus expiratory fluoroscopy images. You can clearly see that during this is inspiration, and this is expiration radiograph. Okay, expiration. So you can see that during inspiration the trachea is patent. Okay, trachea, there isn't any problem, but during expiration you can see the collapse of the thoracic portion of or intrathoracic trachea. Okay, so you need fluoroscopy for tracheal collapse diagnosis. So this is all about the larynx and trachea radiography pathology, the upper airway system. Next we will go for the radiography pathology of esophagus. Okay, esophagus, though it is part of the digestive system, but also it comes under the thorax. Okay, in radiography mostly it present in thorax. So we will discuss the radiography pathology of esophagus. So till then, tata, bye bye, take care.